we're good to go.
Perfect, thank you. Just brief introduction to myself. For those of you that don't know me, I am Kirsten Sinclair. I'm one of the members of the Celtic SMR healthcare team, probably more commonly known by many of you for my therapeutic equipment demonstrations. But tonight we have got Mike Grice with us doing our introduction to scanning commonly seen lower limb pathologies, so ultrasound for you guys. We've also got Tom. Tom is one of the account managers at Celtic, so I have to duck out early tonight. So I'm doing the introductions and then Tom's going to take over from me at the end. So just a quick introduction to Mike before he cracks on with his stuff. So Mike, and this is, by the way, quite an impressive introduction, so bear with me while I go through. I've greatly shortened the information I have on Mike. It's very impressive and it's hard to know which bits to skip. So Mike founded Movement Therapy Education in 2003, which is a leading institution dedicated to health, fitness and therapy training. He's an esteemed lecturer for both FDSC and BSc sports therapy programs at University College Birmingham. Mike also acts as a guest lecturer across prestigious institutions in the UK, USA and Europe. His extensive knowledge is sought after by Premier League and Championship football clubs, where he conducts specialised training sessions, particularly in the delivery of shockwave and sonography. Mike has an extensive experience in the corporate sector, consulting with various industry leaders. In addition to all that, he's also a regular on the conference circuit. Mike, do you ever stop? Speaking at many renowned conferences, his notable presentation at the 2014 IOC World Conference for Injury Prevention in Monaco underscores his global influence. And by the way, if you don't know what the IOC is, it's the International Olympic Committee. So it's safe to say that you guys are in very experienced and very good hands tonight. So with that, I'll pass over to you, Mike, and let you teach us all the things you've got to share.
Cool. Thank you very much. Yeah, it's quite embarrassing actually having someone introduce me. Thank you for turning up tonight on a Wednesday, dark Wednesday evening. So what I'm going to do is I'm going to teach. It's what I do if I do a face-to-face course. And going to teach the introduction to using an ultrasound machine, the kind of images that you can get. And I've recorded some video of showing me scanning so I can show you the basics for the lower limb. And I'm going to teach it as if you know absolutely nothing. So if you know nothing, obviously that's great. But if you know stuff, then bear with me because I think sometimes it's useful to go over things again anyway and just get a good kind of grounding of the basics. So you may have a machine already and you bought it and you haven't really done any training on it, so you're not really getting the best images. Or maybe you're thinking about getting a machine and you're wondering, well, is it really worth it with my clinical practice? What kind of value is it going to add? So those are the kind of things that hopefully we'll cover today. As Kirsten said, I run Movement Therapy Education, and just a quick plug. I'll show you there's a QR code at the end to scan, but I'm doing some face-to-face training. So if you think that this has been beneficial when you want to do some hands-on stuff, then I do a day face-to-face training as well. So I'll let you know about that at the end of today. So this is me in a nutshell. I've got a couple of kids that are a bit older than this now. So my son's nearly finished uni. He's doing fashion design. And my daughter wants to be an architect. So I had absolutely no influence on them whatsoever. They've gone in completely separate directions to me. We have now 3 dogs. They're all rescue dogs from Crete. So they keep us really busy as well. If you're interested, I do. So this is King's College in London. I teach anatomy at King's a couple of times a year. So that we can get external people who are not on a degree at King's into the anatomy labs. So if you've not done that kind of thing before, or you've not done it for a while, then again, just drop me a message and I'll let you know when my next one is. This was me learning ultrasound during, you can guess, COVID. It was horrendous in all that get up. And of course, when you're scanning, you have to have quite a dark room. So it was a dark room, fully togged up with all the gear. And yeah, it was just absolutely, it was a horrendous time to learn. I think it really was. But there we go. I've written a chapter in a book. So this is sports therapy, injury assessment, rehab. So if you're struggling to get to sleep at night, then I wrote chapter 2, so you can have a look at that one. And then, as Kirstin mentioned, I did some work with the IOC over 10 years ago now. So yeah, it's probably one of the most daunting lectures I've ever delivered. That one. So today is all about this. I'll be introducing you to ultrasound devices. I've got one myself from Celtic, and that's why I teamed up with these guys, because I know the machines, the Sonoscape machines, and I have used some of the other ones as well, but every day in practice I use my Sonoscape. I've had it for about 5 years, and I started off with a handheld device. It was a butterfly probe, and when I got my hands on a laptop, it was just night and day, the kind of images that you can get. And I often get asked what's the best for my practice, and to be honest with you, it's best to have a go. So if you are wanting to do measurements of like the tiniest millimeters of calcifications, you need a pretty decent machine. Yeah, so you're going to need at least a top end laptop for that kind of image quality. If you just want to see whether the Achilles is still attached and to what extent it's still attached, then a handheld probe is usually pretty good. You can get fairly decent images, but the kind of quality is very different between the devices, and that is born in the price that you're going to pay. So the handheld devices are around about £2,000-3,000. Sometimes they're a little bit more, and you're looking at least sort of 10,000-12,000 for a decent laptop. So again, obviously, it's a big investment if you're going to go for it. So it needs to be something that you're going to use, and hopefully, I'll help you get the best out of it today, or at least kind of give you some ideas about which one to choose. So going to have a look at basic structure of a machine, and then how you choose your probe, depending on what kind of things that you want to scan. So these are your kind of main components. So I've chosen a laptop scanner as the picture because that's the one that I use, but you can have a cart-based model as well, which is obviously not so portable. You have to keep it in your clinic room, but it's pretty much the same setup. So you're going to have a monitor, and you're going to have a control panel, and depending on the size of the machine will depend on the kind of image quality that you get. With MSK ultrasound, which is purely what I do, I don't do any visceral scanning, don't do vascular scanning. I just do literally muscles, tendons, bones, ligaments, nerves. Okay, that's pretty much it. And the best probe for that is what we call a linear probe. So this is a linear probe just here. And then obviously you need to take out shares in ultrasound gel because you will go through a lot of gel when you're scanning. The probe itself, if you're scanning something and you don't have the right amount of gel on, then the ultrasound won't be able to put the ultrasound waves won't be able to pass through the skin through the to get to the tissues that you want, because the skin is a barrier. So you need plenty of ultrasound gel to make sure that when you're trying to get a decent image, you're not being hampered by lack of gel. And sometimes, and I'll show you some images in a second, if you've got a gap in the gel or there's not enough on the skin, then you will have dark spots in the image and it will look like an injury. So, for example, if you're scanning over the Achilles and you just don't have enough gel, you might go over a section and then literally it's dark and you think, wow, that there's been a big rupture at that point. But actually it's just because you've not got enough gel on. So that's one of the first things that you need to make sure. Have you got enough gel? We're going to talk about how to get different depths of imaging. So if you're scanning something, so for example, if you're scanning the flexor hallucis longus, it's fairly deep. I'm looking at a couple of centimeters, 2-3 centimeters, and maybe a little bit more depending on the size of the person. And if you want to scan deep, then you can change the settings, and I'll show you how to do that. But if you want something superficial, like for example, the enthesis of the Achilles, then what you may want to do is build up a what we call a standoff. So you pile a load of ultrasound gel on the back of the heel, and then you rest the probe in the ultrasound gel so that the probe is a few centimeters away from touching the skin. And what that will do, because of the amount of gel you've got there and because of the distance you are away from the skin, it's a really good way to image those superficial tissues. So if you're dealing with the foot, if you're a podiatrist, then that's a nice little technique to get some really decent quality images of the foot and the bony anatomy, especially around that area. So your gel and your probe are, I mean, it sounds obvious, doesn't it? You obviously need a probe and you need some gel, but you can manipulate how you use them to change the kind of images that you get. Okay, so that's one of the first tips, really. So when you scan tissue, this is what you see. Okay, so on the right-hand side of the screen, you will see these markers, and they are depth markers. So we've got 1 centimeter depth, 2 centimeters, 3 centimeters on this image. And then if we have a look along here, you've got the different types of tissue at those different levels. So obviously we've got the skin level here. So this is a normal image of normal kind of structures. Then you've got the subcutaneous fat layer. So and it's kind of globular in the way that it looks. And if you've got a lipoma or something like that, you'll see that in that particular layer. Then you've got so this layer here will be a fascial layer, so that it's quite bright. In fact, we'll talk about that in a second. There's another fascial layer just there. Okay, so we've got superficial fascial layers, and then we've got muscle tissue underneath, which is a lot darker. And can you see these little flecks of white just around here? So those are the connective tissue within the muscle. So if you remember back to kind of day one anatomy, where you have that model where you've got a tendon, and then you've got a bundle of muscle fibers, and then you've got a single muscle fiber, and then that's wrapped in connective tissue. That's basically what we're seeing here. So connective tissue is really quite bright. We can see that really well on the imaging. But that's what you would normally see is those layers. And again, I'll show you some images in a second. So I think one of the first things that I wanted to start with, because that image before is what you should see and what is normal. But it's also useful to know when things aren't quite right, because you can have a lot of things that cause changes in an image, which can make you think that there's a real bad problem. Okay, so like that there's a tear in a muscle, or a complete rupture, maybe even just a small little change in the tissue, and you're thinking, oh, is that a tear there? And all it is the handling of the device or the incorrect selection of the settings. Okay, so I'm going to go through some of the things that can go wrong so that you can adjust the settings to make sure that it is something wrong, or you might have just needed to adjust the probe a little bit to get it in the right place. So we've got these things called artifacts, and an ultrasound artifact is any discrepancy between the images displayed on the screen and then the actual tissues or structures that you're scanning. Okay, so you're seeing something on the screen, but it's not matching what is actually going on with the tissue. And we've got to be really careful that we don't draw a clinical conclusion on faulty information. Okay, so it's really useful to know that there are some problems that can occur. So these artifacts arise due to physical properties of ultrasound waves and the way they interact with human tissue. So some tissue, ultrasound will be able to pass through it, no problem. Some tissue, it will slow down the speed at which the ultrasound can pass through. And depending on what structures are there, or depending on how you've positioned the probe or how much gel you've used, for example, like I said before, it will change the kind of image that you get. And obviously we want to get a really good image to make a good decision. Okay. Common causes of artifacts include a reflection, a refraction, and an attenuation of the ultrasound waves as they pass through the tissue. So I'm going to show you some examples of those now. So this is a scan, or sure what this is. It looks like a visceral scan, to be honest. So not my area. I've just picked this up off the net just to show you the differences between the different types of brightness. So we've got anechoic, a complete or near absence of returning sound waves, and the area is black. So if we have a look anechoic here, there's a completely black area there, and in your notes you would write that there's an anechoic region and then which level it was found at. Okay, obviously if you know the anatomical structure, then you can name the structure. Hypoechoic is a structure that has very few echoes and appears darker than the surrounding tissue. So hypo is up here. And can you see there's elements of white there? So there's something there. It's not completely dark, so it's not anechoic, but it's hypoechoic. So there's not as much brightness. And then we've got hyper, which is large amplitude of returning echoes that appear brighter than the surrounding tissue. So that area there is really hyperechoic. It's very, very bright. Okay. So that's the kind of terminology we would use for those different levels of the kind of images that we can see. Okay, so that will be useful as we go through. Let's click on that. Here we go. So these are some of the things that you might see and you think, oh, what's going on there? And by changing the settings, and I'll show you how to do that in a second, we can make sure that what we're seeing is real rather than an artifact, so rather than made up. Okay, so you may get shadowing. So this is a region of hypo-intense signal distal to high attenuation objects such as bone. So sound waves, ultrasound, can't pass through bone. So as soon as it hits bone, it will bounce back into the probe and you won't be able to see behind it. Okay, so if we have a look here, this is a gallstone, so you can see the stone just there, and behind it, there's shadowing. And it's because as the sound waves are coming down, they're bouncing back off of the bone or off of the calcification in this example. And because it can't pass through, it doesn't know what's behind that calcification. So it ends up shadowing. And if you have a look here on this image here, so you can see that hyperechoic area there. So it's really, really bright. Then there's anechoic. So it's really dark. Then you've got this stone, but then behind the stone, it looks like there's a hole. Yeah. So see that gap between that structure there. So because the ultrasound can't get through that calcification, you can't see behind it. And there's a shadow there. Okay. So that can be useful or it might not be. So if you've got a calcification in a tendon, so for example, if you're looking at the Achilles or you're looking at supraspinatus and you think that there's a calcification there, if there is, it will block the ultrasound passing through it. So you won't be able to see the structures underneath that calcification. Okay. But the good thing is with musculoskeletal scanning is you can move things around. Yeah, so if I move the tendon around, then I can see whether the calcification moves with it, or if there is a hole underneath, basically. So is it a tear, or is it because the calcification is blocking? And by moving around, you can assess that. Okay, so that's one artifact. Then we've got this one, which is completely the opposite. So this is enhancement. I'll just move me out of the way. So this is a region of hyper intense signal distal to the low attenuation objects. And this is usually found with fluid. So if you have swelling of something and you scan it and there's this black blob like that, if it's fluid, because ultrasound passes through fluid really well, really easily, so that hence using ultrasound gel, it will make whatever's behind it really bright. So this is really useful, especially when scanning around feet. So if you've got a pocket of swelling in an area around the foot, and then you scan over that area and you see this black blob, the bone underneath it will be really, really bright, because it the ultrasound can pass through that fluid really easily, and because it's able to do that, it will actually increase, it will make it, the area underneath it, hyper-echoic. So you'll get a really bright image come back off of the reflective bone, compared to the bone either side of the swelling. Okay, so it again, it helps you with your diagnosis, because you know that it's swelling that's there. Okay, this will that a kind of black blob like this, if it's like it can be different kinds of liquid. So you could have a cyst, you could have swelling, so you could have edema. You might have, if you've got other lumps and bumps like lipomas, they all look slightly different. But if you've got like pure liquid, like swelling, it will definitely be like this. Okay, and you'll be able to tell straight away, because of the acoustic enhancement, that there is fluid around that region. Okay. Now, this one's useful if you do any kind of needling. And what happens with the ultrasound here is it doesn't, because the way that ultrasound works is as the ultrasound comes down, so it's like sonar on a ship, yeah, when it's bouncing off the bottom of the seabed, coming back up to the ship, and then you're mapping out the levels of the seabed. If you remember that from kind of GCSE science. So that's basically what's happening with the ultrasound waves. And when it hits a metal object, so when ultrasound hits a metal object, it doesn't quite know what to do with the information, because basically the computer makes an image based on what it's hitting, and then that's why we get the images we do on the screen. So when you use a needle, you can get this reverberation. Yeah, so and it's kind of bouncing back and forward, and what it does then is it kind of multiplies the image, and it looks as if there's loads of needles going into the skin, or whatever you're needling. You can change the settings on the machine. It's not my area of expertise, because I don't do injections, but you can change the settings so that you don't get that reverb effect. Okay, so but just to let you know, so if someone has metal work from an operation, you may get some reverberation. And also, there was a story about somebody who'd done some imaging on someone. I think they were in their 70s. And when they were in their 20s, they were messing around and on a metal fence. And a bit of the metal fence went in their leg. And then they didn't think anything of it. And then years later, their leg started to hurt. So they got scanning done to see whether there was anything wrong with the musculoskeletal structures. And there was this reverb. And they were like, what the heck is this? And it was a bit of that metal fence was still in their leg all these years later. And they could see the reverb effect when they did the imaging. So bit of a random one, but you never know. And then we've got this. This is the most common thing, really. It's an isotropy. So this is the property of tendons, nerves, muscles they vary depending on the angle of the ultrasound beam. So this image here is of a supraspinatus tendon, and because it's curving over the head of the humerus, and your ultrasound probe is linear, you get as it curves around, you're going to get longer beams on the edges, so longer waves coming down and then back again, and then in the middle there's going to be shorter. So what the ultrasound machine will do is try to create an image from the information it's receiving, and because of the curve, if you have a look here, there's a dark spot. Yeah, so you might scan that tendon and go, oh, it looks like they've ruptured that area, or it looks like that there may be a bit of swelling there, a bit of edema. If there was edema, then behind it would be acoustically enhanced, so like the other image. But then if you move the shoulder a little bit, or you move the probe, then it fills in the gap, and then there's no problem. Yeah, so, and this is one of the most common mistakes, is all you needed to do was just move the probe around to try and get perpendicular to the tissues, and then as soon as you do that, it fills in the gap, and then everything's okay. All right, so that's a real common one, is the anisotropy, and I've got another image of that a little bit later. So these are all the different ways in which you can manipulate the probe, and it's useful if you've never really done this before. The Achilles is perfect to start on, because it's nice and superficial. Everybody knows the structures. If you work in MSK, then Achilles structures are really easy to get your head around, and it lends itself perfectly to playing around with your probe handling. Okay, so if you're going along the tendon, so from side to side, either in what we call a long view. So if you've got the probe like this, and you place it like that, so say along my extensor tendons, and you run the probe backwards and forwards like that, what you will see is you'll see the long striations of the muscle. And then if you flip the probe around so it's that way round and up and down, then you'll see a cross-sectional view. Okay, so you just switch the probe and it will go from a long view, so along the muscles, and I'll show you this as we go through, or a cross-sectional view with this one here. Okay, and then B, we've got a heel-toe action. Yeah, so if you're on the shoulder and you're imaging that supraspinatus tendon, because it's curved, you're going to need to curve the probe around that curve of the tendon. If you just put it on dead straight and the tendons curve like this, you're going to get longer sound waves on either end and then shorter sound waves in the middle. So you may get a bit of an anisotropy. So all you do is you just curve the probe around to try and maintain that perpendicular edge to that tendon, right? And that's called heel toeing. It sounds quite obvious, but it's quite a hard thing to do. And because you don't need much movement at all, you just need slight little bits of movement. So the best thing to do is to hold the probe really, really close and have the heel of your hand in contact with the skin, so that you're not like this. Okay, you're not holding from afar, you're holding really close down, and then you've got much more control over the probe as you're trying to maneuver it around, and you'll move it like millimeters. And that's all it will take. If you move it a millimeter one way or a millimeter the other, you'll be off the tendon, and then millimeter the other way, you'll be back on it again. So these small little movements are really quite useful. Then we've got C, which is a tilt. So tilting backwards and forwards. And again, the tendons are sometimes twisted. So the Achilles tendon twists as it attaches into the calcaneus. So you might need to just tilt the probe to keep the fibers aligned as it twists in. Okay, and obviously everyone's slightly different. So you plonk it on their Achilles and you think it's all going to be straight, but you might be missing some bits, and it's because you haven't quite got the angle. You need to tilt it a little bit to get the whole image in. And then D, we've got compression. So if you've got quite a lot of tissue and you want to get down to deeper structures, you might need to compress down and use the probe to push the superficial tissues, the subcutaneous fat mainly, out of the way. Okay, otherwise it won't be able to penetrate deep enough to give you the images that you want. Yeah, so that's that one. And then we've got rotation. That's really useful for the bicep tendon. So if you have the probe like this on the biceps, so imagine that was the bicep tendon there, I can have a look at it in long view. Okay, so along the fibers. And then if I keep the tendon in the middle of my screen, I can then twist like that and then scan up and down, and then I've got it in a short view or a cross-sectional view. Now that takes some practice. Okay, so you get, and you can do it with the Achilles as well. So you get long view of the Achilles or the biceps. Keep the tendon in the middle of the screen, and then you twist, and then you've got then a cross-sectional view. That is really difficult to do, and it does take some time to master that skill. And then the last couple, we've got a pivot. This is useful for again for the Achilles, is really good. So this edge here on the F there, we will keep that on the calcaneus. Okay, and then what we'll do is we'll pivot the probe, but keeping one point on the calcaneus. So imagine that's the calcaneus point there, and Achilles is going that way. I'll keep that edge on the calcaneus so I know that I'm on it, and then I'll just pivot the probe like this to then try and align up the Achilles in the center. Okay, so you can keep that point the same. So you use the bony anatomy to maintain that position, and then you just rotate to try and get that tendon in the right place. And then this last one, these are your standoffs, as I was saying before. So you use a whole bunch of gel. You bring the probe away from the skin, and this is really good for imaging superficial tissue. So if you want a nice, clear image of the enthesis of the Achilles, this is a really nice way of doing it. Okay, so you can use that example there. Cool. Okay, so just to break up from me a little bit, I'm going to show you some videos. So we're going to have a look, first of all, at how you change your frequency and then how that affects your images. Okay, so frequency looks like this. Hopefully it's the right video. Okay, so if you have a machine, then this will be great. If you haven't, wait until you bought one, and then you can follow the video and you can adjust the frequency. So on my machine, I've got these dials here, which are just underneath the main laptop screen. And if you press the buttons, it flicks between focal span and frequency. So, and you just press the button to change between the two. And then on the button, you can see it on this one a little bit clearer, there's this black ring around the button. And when you twist it, it will change from focal span to frequency. Okay, so if I just go back a sec there, I'll just show you this again. So there's me changing it to frequency, so between the two. And then just up in that top left corner, can you see there? It's got 9.0 to 13.8. Now, good scanning for superficial tissues, you need a high frequency. And I'll talk to you about why in a second. Okay, so on your machine, like something like this, you will be able to change the frequency setting depending on the probe that you've got. So some probes will give you a higher frequency, some probes will give you a lower frequency. Low frequency probes are good for really deep structures. So they're usually used for visceral scanning. So if you're going to scan the abdomen, you'll need a low frequency probe. If you're doing MSK, you need a high frequency. So have a look here and see what happens when I just twist this button, and you'll see what happens to my frequency. Okay, so that's what to look at. And then as I twist it, there we go. So my probe goes up to 14.6. Yeah. So that's 14.6, or between 11.5 and 14.6. So what that means is now I've just changed the settings there to make it better image quality for a superficial scan. Okay, so if I'm scanning something in the foot, if I'm scanning a bicep tendon, supraspinatus, anything like that, which is quite superficial, then I want a really high frequency. And this is the reason why. Just go back to this. So hopefully you can see this okay. So we've got long wavelength, low frequency. Yeah. So again, going back to tough GCSE science, or maybe A levels. So we've got a wavelength here. Okay. And when you set the frequency low, then the wavelength is bigger. So what that means is that the ultrasound waves will be able to pass through deeper tissue to get deeper. Okay. And if you compare that to this image here, where the wavelength is a lot smaller, the frequency is a lot higher. So can you see how many times it's sending a sound wave for exactly the same distance is much greater. So what that means is that it won't be able to pass through as much tissue, because as the sound waves are going through, they're going to get soaked up by the tissue that is in the way. Yeah. So if the sound waves are close together, it's not going to get very far because it's got to hit something and then bounce back again. But if there's a bit of a gap between the sound waves, so the frequency is lower, then those sound waves are going to get deeper. Yeah. But the problem is, if you have a look at this here, so we've got a low frequency probe versus a high frequency probe. So this is a linear probe between 5 and 15 megahertz. So if you remember on my one, it went up to 14.6. So we've got at a low frequency, we don't get a very good penetration, but we get a really, really good image. Okay. But with a low frequency probe, we get a really good depth, but the image quality is really poor. So if you want to scan something deep, so if you say, for example, a glute tendon, which is a few centimeters deep, you might need to adjust your frequency down so that the sound waves are bigger, the ultrasound waves are bigger, so that it can penetrate more easily through to the deeper tissue. But the image quality is not going to be anywhere near as good as when the frequency is high and they're closer together and you're scanning superficial tissue. So you have to compromise. Yeah. So if you want a good image, you need high frequency, and that's superficial tissue. But the deeper structures, the image quality just isn't going to be as good, depending on the machine you've got and depending on the probe you've got. Okay, so obviously there are probes that are specific for scanning deeper structures, but MSK, we tend to use these. Okay, and like I said, this one goes up to, well, on mine, 14.6. Okay, so the lower frequency can see deeper, but the image quality is not as good. All right. Now, I showed you this a little bit before. So we've got the depth scale on the side here. Okay. And let me just show you on my machine. So depending on what you're scanning, you're going to need to change the depth at which you want the machine to focus on. So if I just pause that there. So can you see here? So we've got 0 is where the skin is. Then we've got 1 centimeter, 2 centimeter, 3 and 4. So that's the depth or that you're asking the machine to scan down to is 4 centimeters. Now, if you're imaging the Achilles tendon, the Achilles insertion, you don't need that amount of depth. So the machine will be trying to scan down that deep, but you'll be wasting the energy of the machine because really you want to focus on those top 2 centimeters. So what you can do is there is a button on here, just show you in a sec on mine. So those are the depths, and then there's the button there. And as I flick it, it will decrease the depth. So now on the side of the machine, I've got 0, 1, and 2. So I'm just asking the machine to concentrate on those top 2 centimeters. So if you know how deep a structure is, then you can adjust the depth setting so that you can ask the machine to focus all of its energy into looking at that top 2 centimeters. If when you're looking at an image, you've got a load of dark on the bottom of the screen, you need to adjust the depth, because you're kind of wasting the bottom of the screen if you've got too much darkness there, because you don't need to look at that level of depth for superficial structures. Obviously you do if you're trying to have a look at them deeper. So that's your depth setting. And if we have a look here, this is looks like it's a bit of bone to me. So we've got 4 centimeters here, so that's 4 centimeter depth, 5 centimeters, 6 centimeters, 7 and 8. So they've kept the probe in the same place, but they've just changed the depth of the screen. And can you see the brightness has gone? Yeah, so there it's quite bright, there it's fairly bright, and then as you get to 6 centimeters, this is looking pretty dull, and then when you get to 8, you can you can just about make it out. And it's because the machine is trying to take in that 8 centimeters of depth, when really you just want to focus on that top 4 centimeters. So you're wasting the energy of the machine if your depth settings are wrong. Okay, so if you have a look at this image here, there's a load of white underneath there, and we don't need that if we want to focus on that top bit just there. So we can change the depth to bring the screen up. Okay, and again I'll show you that in action in a second. So that's your depth. Then you can change your focus and something called time gain compensation. So you can ask the machine to focus on certain bits of the anatomy. So I'll just show you this, and then hopefully it will make a bit more sense. So there's the depth down the side. Okay, so we've got 1 centimeter, 2, 3, 4. And then hopefully you'll be able to see, I think we zoom in a minute, where there's a little red arrow next to that 2, that number 2 just there. So I want you to keep an eye on that red arrow. So just there. There you go. You can see it just there. So what I can do, I can change the focus. So I press the focus button. And what it will do is it will move that arrow up and down the depth. Can you see it there? So it's gone up to 1/2 centimeter, 1, 1.5. So if you have got, I'll just pause that there. Let's say you're scanning, again, we'll use the Achilles as an example. So let's say we want to have a look at kind of around the fat pad. Okay, so we want to have a look at the Achilles fat pad, and you want the machine to focus on that specific level. So you get your depth sorted, so down to around about 3 centimeters, and then you change your focus to focus on that exact level where the fat pad is. And then all of the energy of the machine will focus on that specific depth. Okay, so you can really increase the quality of the image all along that focal line. Okay, and then so that's quite a broad adjustment. And then what you can do is you can change specific bits of the image using TGC, so time gain compensation. Now that's what these buttons are here. Okay, and if you have a look at the top, there's a sloping ramp. So if you move the buttons over to the right hand side, it will increase the brightness of the screen, and if you move them all to the left hand side, it will decrease the brightness. So if I wanted to increase the brightness of a specific band along the image, so again, let's say it's the fat pad, then what I would do is I would leave the top two buttons in the same place, then I would move these three up to the right to enhance the brightness of that specific section. And then I would leave these three in the same place. So it's just focusing and concentrating on that specific area that I want to have a look at. So if I just show you what happens on the screen. So on the right-hand side of the screen, can you see that line? Yeah, so the line will change and it will either push it forward or back. So if it's towards the right, it will make it a lot brighter. If you push it towards the left, then it will make it darker. Okay, so you can get specific bits of the anatomy and make it really, really bright. All right, so it really enhances that section, which is quite useful. So that's what these buttons are for here. Okay, and if you have a look at this one, so we've got a real bright area here and then darkness here and here. So look at those two. So those two are completely not to the left. So that means this top part will be black. This bit is really bright. So that bit is lit up. And then these bits dark. And then another bright bit just there. Okay. So you can see how you can manipulate the image to just highlight the sections. So the rows that you want to see. But when they're all left in the middle, that there is exactly the same image as that. Okay, but because we've highlighted certain bits, we've enhanced those particular bits. Sometimes though, like that bit there, that's way too bright. So you kind of overcompensated in that bit. So you might need to just adjust it a little bit so you get a better image. Okay, so you can play around with those rows as well. And then the last thing is the overall gain. So this is like showing me age now, the old black and white TVs where you had to play around with the brightness. Okay, so we've got a gain button on the laptop, and when you turn it, it brightens the whole screen. And then when you turn it the other way, it darkens the whole screen. Okay, so you don't just do the rows like on the last one, you do the whole thing. Yeah, so if you have a look on this image, it's really dark and I can't really make anything out. So that's undergained. This one is too bright, yeah, because I can't really make out some of these structures here because they're all just really, really white. And then this one here is just right because I can see the different kind of fascial layers and the darkness in some areas. So the image quality is much better. Yeah, so you can play around with the gain to get it in the right place. And I'll just show you where that is as well. So this is the gain. Okay, so there's the gain button on my laptop. And then as I rotate it, you'll see, can you see the whole screen just brighten up? And then as I turn it the other way, it gets really dark. So sometimes this is one of the errors that you make when you first start scanning is that you can't see anything. And it's because you've just got the gain too low. Okay, so you're trying to really struggle to make things out. And it's just because you haven't turned that dial. Okay, so you can play around with that gain button to enhance the image as well. Okay. So you've got a lot you can play with with these machines. So we can change the frequency. Is it, and you need to think, this is a nice little checklist. So is it correct for the location of the structure? So if I'm doing something that's deep, I need a low frequency, but I know that the image quality isn't going to be as good. If I'm doing something superficial, I need a high frequency. And what the good thing with the laptops and the cart-based models is you can adjust everything. On the handheld devices, they're preset. So sometimes you can adjust them. It depends on what kind of model you've got. But on the whole, they're preset. So if you're scanning an Achilles, you press the Achilles button and it will automatically adjust the handheld probe so that it matches what it thinks that you might need for an Achilles scan. Okay. And yeah, if you do like a glute tendon setting, then it will adjust it for that. So you won't be able to get some of the more finer adjustments on the handheld scanners as you can on the laptop and the carts. The depth, is the setting correct for the structure location again? So are you wasting some ultrasound waves because you've got the depth setting too big? Okay, so do you need to reduce that down so that you can ask the machine to focus on those top 2 centimeters? Is the focus in the right area? Okay, so using the time gain compensation or that focus button. Yeah, so is it on the right row? Yeah. And then is the gain right? So have you got the whole gain up too high, or is it down too low, or have you got it about right? Okay, so those are the key things that you need to adjust when you're looking at scanning. Okay, so very quickly, and then because I'm just conscious of time, and you guys listening to me go on and on. So I have got some videos of me scanning things. So I'll show you what I do. But before we do that, it's useful to know what different structures look like, or what they should look like when they're normal. So we're going to have a look at bone, cartilage, muscle, tendon, and ligaments, and what they should look like. Okay, so bone should be really bright. All right, so this is a bicep tendon. You've got the greater tubercle, the lesser tubercle, and then the bicep tendon in the middle. Got the transverse humeral ligament over the top. And then the bone is really bright. So bone is bright there, bone is bright there. And what you want to try and do when you're, especially when you're scanning near bone, is get the bone as bright as possible. All right, we use that as a kind of a landmark to make sure that you've got the probe in the right orientation. So you either tilt it, heel toe it, pivot it, whatever you need to do to get that bone as bright as possible. All right, so that's a real key thing. So bone is hyperechoic. It's really, really bright, and it's a really good way of knowing where you are. So if you know your bony landmarks, you put the probe on the bony landmark and you start there, and then you can go off onto the other structures. But that bony landmark is not going to change. So you can go back to it and keep using it as a point of reference. Okay, so that's really important. But as I said, because of the density of bone, ultrasound waves can't pass through. So if you have a look underneath the bone, it's completely black, and it's because you can't see past those structures, and that's how it should be. All right, so it should look that way. If there's a fracture, then you'll see a break in the continuity of the bone, and you'll see defects in the bone structure. Whereas it should be nice and smooth, you might see some defects. Okay, so on some areas with ultrasound, you can see fractures. This is a really cool image. This is on the top of the knee with the knee bent. So we're looking at the femoral condyles, and that kind of pale gray area there is the cartilage. Yeah, so that's what cartilage looks like on imaging. There's kind of like a halo around the bone. All right, that's what it looks like. So that's your cartilage. This is muscle layers, and we looked at this a little bit before. So this is a nice image because you're looking at a thigh. So we've got the skin at the top, subcutaneous fat just there. Then there's a fascial layer, and then here we've got the rectus femoris muscle. So it looks kind of like speckledy. This is a cross-sectional view, so it looks a little bit different to a long view where you can see stripes. This one, because it's end on, so it's cross section, then it looks like a fiber optic cable. So if you have a cable and you cut the end and you have a look down it, and you've got all those little wires coming out, that's basically what this looks like, but it's muscle fibers. Okay, then we've got another fascial layer here. Then you've got the vastus intermedius, but can you see the image quality isn't as good? Yeah, not sure what the depth is there, but there's quite a few centimeters. So rectus femoris shows up really well, but because it will be on a superficial setting, the vastus intermedius, you won't be able to see as well, because the ultrasound has used the energy to see these superficial tissues. And then right underneath, we've got the femur just there. So you can see all the way through straight to the femur on a thigh. Okay, no problem at all. Tendons look stripy. So this is an Achilles. There's the calcaneus. I'll show you how to scan this in a sec. There's Kager's fat pad underneath. You've got flexor hallucis longus. Soleus is just here, kicking in there. And see those white arrows there and there, and there and there. So that, going that way, that is your Achilles tendon. Yeah, so they look like stripes. Yeah, really, really bright stripes. But look how superficial it is. So that's the skin. So it's literally a couple of millimeters, and then you've got the Achilles. So you can see it straight away. Yeah, that's no problem. And then this is a cross-sectional view. So if you turn the probe onto its side, you can have a look end on the tendon. All right, and it looks like that just there. So a good little tip is if you think something is injured and you've got a tear in the tendon or a muscle or whatever it is, it will be there on both views. So if you have a look at it on a long view and you think, oh, it looks as if there's a bit of a tear in that muscle, freeze it, save it, take an image of it, then have a look on a cross-sectional view and scan over again on exactly the same area, because if there is a tear, it will be there on the long view and the short view and the cross-sectional view. Yeah. If it's on one but not the other, it may be an isotropy and you've just not quite got the long view in the correct place. So you might need to heel toe it a little bit more or tilt it and to fill in the gaps. Yeah, so that's something just to be wary of. This is a really good example of an isotropy, and when and the difference between an isotropy and a tear. So this is a curved tendon. So when you're scanning it, obviously the probe is linear, and because it's curved down, you're going to get really good images on some bits, but then other bits where it's not very well aligned are going to look quite dark. So if you just looked at that image there, you would think there was something wrong with that bit of the tendon because it looks darker than the other bit, but it's just because you don't have the probe lined up properly. So if you're scanning anything that's curved, and the bicep tendon is a classic example of that, because the biceps doesn't run straight down, it runs backwards. So you have to really push into the arm and tilt the probe downwards as you're scanning down the biceps. Otherwise, it looks as if there's bits of the tendon missing. Yeah, if you keep it perpendicular with the skin and you don't push in, then it will look as if there's a tear. So again, knowing your anatomy is really important, but handling of the probe as well, and checking on both views, right? And then that's a tear there. So that's a supraspinatus tear just there. You can see there's a defect in the tendon. It's just a bit of it missing. And if you scan that short and long, there would be a difference on both. Ligaments look like this. So there's your MCL just there. That's the knee joint, and then the meniscus there. And I've got a video of me scanning this. I'll show you in a second. So you can see the MCL all the way across there. Yeah. If there's edema in the knee, you've got some kind of articular lesion and there's swelling, then what you'll see is that there'll be leakage of fluid out of the knee joint and usually pushing onto the underside of the medial collateral ligament. And because of gravity, it will start to migrate down the tibia. So you'll see a whole bunch of fluid kind of around this area here. But that again, I'll show you how to scan that. But that's a nice, easy one to scan. Excuse me. But the ligament looks like that. So it's really bright. Ligaments are really, really bright. Cool. Okay. So that's what they all look like. What time are we at? Perfect. Okay. So I've got some little videos here. and I'll just show you these. So this is the Achilles. And I chose my kids to scan because I knew that they'd have nice bright tendons. Nice 17, 18-year-old tendons. They look pretty good. Okay, so let me just move me out of the way. Here's my screen. Okay, so I've got the depth down the side there. Can you see the where the red focus area is here? So I've got this quite deep. And I just on this video, I adjust the depth. So I just want to show you the difference between the kind of things you see if you've got it on too deep a setting compared to a shallower setting. Okay. This image here is from the ESSR guidelines of how to do scans, musculoskeletal scans. So these are free to download on the internet. So if you search ESSR Achilles, then there's a PDF of how to scan the Achilles, literally step by step. And this is the image that they'll show you. Okay, so let's have a look at this. So I'll pop some gel onto the Achilles itself. And then let me just pop that there. So can you see that S in the corner there? So that on different machines, it will be a different setting. But on the Sonoscape machine, it's an S. And in fact, let me just show you this before we get going. So this will help you orientate your probe. And this can be really useful, or it can be quite confusing. So just pause that there. So there's the S, okay? And then on the probe, can you see that little bump there? So there's a little line, and it will be on one side of the probe, but not the other. And what that means is, so on my one, it's there, just there. So if I turn my probe like that, and I have that bump in line with the S that's on the screen, that means that whatever is underneath that part of the probe there will be on the left-hand side of my screen. Whatever's on that bit there will be on the right-hand side. So if I'm imaging something and going side to side like that, and I've got that on the left, which if I move to the left, then the screen will mimic my movements. If I've got the probe the other way around and I move to the left, the screen will go to the right and it will be opposites. So it can get really confusing knowing which bit you're on. Okay, so that's one thing that you can check to make sure you're in the right place. So if I just show you here, so there's the little bump, and then there's the S. And then if you hold the probe in the way that I just had it, then the screen will be lined up. Okay, so if we go back to this video, right, pause that there. So if we have a look down at the ESSR image, there's the calcaneus just there, and then there's the Achilles, and then there's Kager's just underneath. So can you see there's the calcaneus of my daughter's heel just there, and then that structure just up there, that's the Achilles tendon. And then you've got the skin just there. So literally, if we have a look, there's 0 and literally 2 mil, and then you're onto the Achilles pretty much straight away. Now, if there's any bursa that's inflamed in that area, then it will show up as a black blob. So if you remember, the fluid shows up black, and then behind it will be enhanced because ultrasound can pass through that fluid really easily. So, but usually you can't see bursa unless they're inflamed or there's some kind of irritation there. Okay. So what I'm going to do now, I'm just going to change the screen just to show you the difference. Get it going the right way. There we go. So we're going to zoom in quite significantly now. So I want the ultrasound. There we go. So I want it now to focus on those top 2 centimeters. So there's the calcaneus. There's the Achilles just there. So underneath around there, that's going to be Kager's fat pad. So I'm just going to move around. There we go. So I've increased the gain a little bit, get a bit of a brighter image. There we go. Okay, so you can see those fibers now, really nice and bright. Like I say, Kager's fat pad just underneath. And then there's the Achilles all the way through, and you can just follow it all the way down until it turns into the gastroc. And then underneath, we've got the soleus. And what I'll do in a second, just change it slightly. There we go. So there's the calcaneus again. So I go up and down the tendon, long view, just to make sure that everything's as it should be. Okay, so now I've got her foot off the edge of a couch. There's the calcaneus again. There's the Achilles tendon. And I'll get her to wiggle her toe. And there's flexor hallucis longus. Okay, so now I can differentiate between the muscle structures. So there's FHL. So that must be soleus above it. And then there's the Achilles just on the top. And now it's turning into gastroc. And then there's FHL still. And now that's disappearing. So I can gauge the different structures and differentiate between them by getting certain bits of the anatomy to move. And especially in this area, it's quite easy. Okay, so there, yeah, there's your Achilles, there's your calc. And then now we're going to switch the view. So now we've got a short view, and then there's the Achilles end on. Yeah, so that's what it looks like just there. So this is the cable. Yeah, so you've got that fiber optic cable with all those wires in. Cut the end, having a look at it from the end on, and you can see all of the fibers. Yeah, so those are the tendon fibers basically, and you can see them all there. Yeah. If there was swelling, then you would see it circling around the Achilles tendon in the paratenon, okay, or paratendon, whatever you want to call it. But there will be like a ring of dark fluid all the way around it, and then acoustic enhancement either side as well. So it looks like kind of sun rays coming down either side when there's fluid around it. Just see if there's anything more there. But yeah, that's the Achilles in a short view or cross-sectional view. And again, you can make out the twist of the Achilles as well, actually, on this one, because I've had to move around as I'm scanning to keep it in the picture. There we go. So I'm just moving up and down the Achilles now, having a look at the whole thing, just make sure there's nothing wrong. I know there's nothing wrong with this one. And then you can follow it all the way down onto the enthesis. So that's the calcaneus. And then it disappears. And then it reappears again. And you can follow it all the way through as it merges into the calf again. Cool. So that's the Achilles. If I just go to this, just show you this. So that's this is the information that you get from the ESSR. All right, so calcaneus, there's your Achilles tendon, Kager's fat pad, soleus, flexor hallucis longus, just there. And then that's the recommended position that they want people to be in. For me, what you don't want to happen is someone's foot to go into plantar flexion, because if you do that, you then slacken the tendon and then it bows. So when you're scanning it, it's got that dip. And then you've got to maneuver the probe around the dip to make sure that you don't get anisotropy. So if you have someone's foot on the couch and you have their on their toes, so that the Achilles is nice and stretched, you get a much better image. Okay, as if they keep their foot dorsiflex, then it's okay. But I find it easier if you put their toes on the couch. But either way, you'll get a good image. Okay, so that's the Achilles. And then the next one, I know we've got a few podiatrists in, so here's plantar fascia. So it's recommended that you look at the plantar fascia in the same position as the Achilles, but I couldn't get the video and do that at the same time. So what I did was I just got my daughter lying on her side, and got to dorsiflex the foot, but I mean, you can see the plantar fascia there. So what you want to do is palpate the medial aspect of the calcaneus where the plantar fascia attaches. You can feel the calcaneus, and then you can see the plantar fascia. The only problem is with this video is it is the opposite way around to this image. Okay, so, and I couldn't flip it because it looked weird. But you'll get the idea. So there I am palpating the medial calc, and then there's the plantar fascia. I'll just play around. There we go. There it is there. And then that's it attaching into there. So you can see there was a bit of a defect then, if I just go back, but it was just an isotropy. So yeah, if I pause that there. So there's the fascia coming in, and can you see that dark spot there? And then there's the calcaneus. So you might think, oh God, there's a tear in the plantar fascia. But as I maneuver the probe around, I can fill that gap. There we go, it's filled. Yeah. So I know, there we go, now it's full. So I know that there's nothing wrong with it. It was just the position that had the probe in. And then I wiggle the toes in a minute so you can see the plantar fascia moving. There we go, there it is there. And then I go back to the calcaneus. And then here we go. So I'm just going to wiggle the toe so I can slacken and stretch. There we go. You can see it bending there. So I can slacken and stretch that plantar fascia just to check it dynamically as well. And if they've got a heel spur, you'll see changes on the calcaneus. You'll see like a little calcification on the end. Okay. So that's plantar fascia. Just go back to that one. There we go. So again, that's the recommendation. Okay, so you should have the foot in that position. But like I said, it wasn't conducive for filming. So that's why I did it that way. But you can see as well that the calcaneus is continuous. Sorry, the Achilles is continuous with the plantar fascia. So if you've ever had a look at cadaveric models, it's just one big structure. So you can actually scan the Achilles, come around the calcaneus, and then continue down the plantar fascia, and you can do a whole scan of that whole area really quickly. Right, so that's the PF. And then last couple, so this is the patellar tendon. So I've got the knee bent. Okay, I'm going to use the inferior pole of the patella as my bony landmark to use. And this is what it should look like. Okay, so there's the tibia. And where it attaches into the tibia, there's like a double bump. If you get someone with Osgood Schlatters, this is where you'll see it. And there'll be a significant difference in the tibia. So this is really nice and smooth. If you just Google Osgood Schlatters ultrasound imaging, you'll be able to see the differences of what it looks like. Okay, there's a significant difference. And obviously, if it's in an acute setting, an irritable state, then there'll be swelling around the area as well. So you'll see edema. But there's the patellar tendon there. And then that right on the end there where the P is, that's the end of the patella. Yeah, so you've got the inferior pole of the patella. And then you can see Hoffer's fat pad just here. And then where that arrow is and that arrow is in between, that's the tendon. Okay, so let's have a look at that. So again, I'm lining up that edge, so that S, with the patella. So I know the patella is going to be here. That's just the way I scan. You can do it the other way around. It's up to you. But I've always done it that way. So I'm lining up. There we go. So there's the patella just there. And then there's the tendon just coming off it there. So I'll follow the tendon all the way down. And then as it attaches into the tibia, see the double bump? So that's entirely normal. Yeah. And then all the way back again onto the patella, just there. Hoffer's is underneath here. And then there it is in a short view. Up onto the patella, and then there it is there. Okay, so again, this is end on. So looking at the muscle, the tendon fibers as they're coming down, and then all the way down into the tibia just here. Yeah, so I can check it in both directions. So short view and long view to see if there's any defects in that tissue. And there it is there again. Okay, so that's scanning the patella. And then the last one, just go back to here. So that's the image again that you get from the ESSR and the information of how to do it. So yeah, you got your double bump on the tibia. There's the patellar tendon, and then the P is the patella. HFP is your Hoffer's fat pad. Okay, so that's all that there. You've got your deep infrapatellar bursa, which is that bit there. Okay, so you can see a little bit of a dark spot there, so that it's you shouldn't really see that. So there's a bit of information there, but then that's what it looks like in a short view. Yeah, so there's kind of like flat, squidgy sausage type shape. But again, if you remember, it's like looking at the end on of a cable. So all of those tendon fibers, they're cut down, and then you're looking at the end of them there. Okay, last one is the medial knee. This is a slightly older knee. This is my son's. So we're looking at early 20s, still quite a young one. So looking at the medial knee here, you palpate the joint line. And again, I'm just pressing the end of the probe to check which bit's which. So I'm trying to line up my probe with the screen. So I've got this end here in line with the S. Okay, so I know which way I'm going. So if we have a look at the image here, there's the femur, there's your tibia. Where that star is, that's the meniscus. So you can see the outer edge of the medial meniscus. Yeah, it looks like a wedge from a Trivial Pursuit game. Okay, so it's like that, and then curved around the top. So it looks like a Trivial Pursuit wedge shoved into that joint space. And if there's any fluid there, any edema, then it will come up, push onto the undersurface of this, which is your medial collateral ligament, and then it will drift down the tibia. Yeah, so that's usually what you'll see. So let's have a look at the, I mean, there's nothing wrong with his knee, so you should be able to see it, no problem. So there's the joint line just there. You can see the meniscus just there. And then there's the medial collateral ligament just on the top. Meniscus just in the middle there. So I'm just playing around with the angles just to show you, if you're slightly off, you won't be able to see anything. Yeah, I'm just going to go back again because that's quite a quick one. Yeah, so if you've tilted it in the wrong direction or heel-toed it a bit too far, you won't see anything. It will be black. Yeah, so you'll see some bits really black and then some bits really dark. Here we go. So there's the meniscus in there. Femur, tibia, medial collateral across the top. And then I'll just show you now as I kind of tilt the probe. So there you can't see anything. There you can't see anything, but somewhere in the middle, that's where you get your best image. Okay, so you just need to play around with it. There. Cool. And that's it. Done. Not bad. An hour and 20. Sorry for going on so much. Hopefully that was useful. If anybody's got any questions, happy to take some. Obviously, I know it's late and you might be a bit brain fried if you've never really done this before. So you might think of things afterwards. So I'm more than happy to take questions after as well. Up to you. Okay, so I can't see any questions. Tom, so
I've
if
got
you've got some
visibility, so you're all good. Thanks, Mike. That was yeah, really fab. My ends, and there's some positive feedback going on
Cool.
on the screen there. Um, guys, if you missed anything, I know there's a few people going in and out. This webinar is going to be sent out, so I have been recording it, and it's going to be sent out to everybody who came on today. If anyone's got any questions, because I haven't seen any coming in at the moment, so well done, Mike. That's good when no one's got
Stunned
anything.
silence. Yeah.
Okay, we've got one here from Oliver Bassett. So, do you use hypervascular on Doppler to detect injury?
Do you use
hypervascular on Doppler to detect injury?
Yeah, you can do. Yeah. So if you what the Doppler will pick up is fluid movement. So if you've got an area that is inflamed and you use the Doppler on a high setting, then it will go really, really speckledy and it will flicker. But what you've got to be careful of is you don't move the probe, because if you move the probe and you've got it on that setting, it will pick up the movement of the probe rather than the fluid movement underneath. But yes, I would. Yeah.
Oliver, you can come off mute if you want to come back to that. I'm assuming. Maybe you can't. Yeah, that helps. Thanks. Great. Lewis says, if we wanted to get further training for imaging in private MSK physio, where might we find it? Well, that is a magic question. I think might have paid you for that one.
My most important slide, I nearly forgot. So I have a training academy in the Shropshire Hills. It's in a place called Ludlow, and the two QR codes to either side of the image in the middle, those are my next courses for face-to-face. So I've got one in a couple of weeks, 16th of March, and then one on the 3rd of August. So if you want to make a weekend, come away to Ludlow as well, come see the castle. And then the one in the middle, that is my next visit to KCL, King's College. We've got about I usually take about 20 students on that one, and we've got 8 spaces left for July. So if you're interested in coming to see some cadaveric material, then more than welcome to come see that. What I do on that day is I take my portable scanner with me. So what you can do is you can scan, say, your wrist, have a look at it on the iPad, and then have a look at the cadaver to try and orientate the anatomy. So I do specific sonography with anatomy on that day.
Wow, cool. Yeah, and those QR codes will be on the recording. So
Cool.
if anyone's not sure, they'll have that as well. Another question, this one from John. Hi, John. If you're unsure of a finding, is there any site that you can get your images checked? So if you save your images, can you get them checked by anyone?
See, really, you need a mentor. That's the best thing I can suggest is finding someone who will check them for you in your area. I don't know of any sites, but you can use the ESSR guidelines, and that will show you the differences with pathology and normal anatomy. But they won't check it. You would just need to check it yourself against their images. But yeah, the best thing I can suggest really is having someone local who you can work with, because I would do the same. So there's a chap near me. I've got one guy who's a podiatrist, another guy who's a physio, and if I've got something that I'm not quite sure of, then I'll send it over to those guys for a second opinion. So I use my kind of people locally.
I'll just sort of weigh in there as well. So there's another question from Terry about mentorship for ultrasound, and obviously we supply ultrasound scanners. So we've got a hell of a lot of customers in the UK and in Ireland, some of whom have been scanning for, sort of 10 years. So if any of you are at that same point where John is, where you want a little bit more advice, maybe potentially some mentorship, get in touch with your account manager directly, and we'll see what we can do about linking you up with someone who's a little bit more experienced. I'm more than happy to do that on a case-by-case basis. So if anyone's not sure and can't find someone to mentor them local to them, then we'll see what we can do with our network as well.
Perfect. I mean, and the thing is with scanning is sonography or sonographer is not a protected title. So you don't officially need any training with it, but if you're a clinician and you do special test, I mean, as soon as I started having scanning available to me, I was thinking, how the hell did I do special tests before and make the decisions I did? Just it was all kind of probability. But now I can do my special tests, and then I can scan it as well and have that information. And now I've got a much more complete picture about what's going on with an individual. So but if you want to write reports, and you can become case accredited, but that's a minimum of a postgrad certificate. So it's a year postgrad training, and at a case accredited school. So if you want to go down that route, where if you just want to add it into your clinical reasoning, then you can, no problem. But if you want to write reports and stuff like that, then you need to do a proper PG cert.
Okay. Yeah, and then there's another question about mentoring, which we've spoken about. One from Oliver again. So, do you measure the size of tendon and compare to non-affected side to point at pathology?
Yep, absolutely. Yeah. What you can do with some machines, you can put them up against each other at the same time. So you can split the screen. You can scan, say, the right side. You can measure it, freeze the image, and then bring up the opposite side of the screen and then scan that one and then freeze that one. And then you can measure the two side by side so you can see it quite clearly. So you can put a dual screen function on. Yeah.
Cool. Yeah, I think that's it. Yeah, I definitely encourage everyone to have a look at these courses that Mike runs. I know that they're really good courses. Just keep an eye out on your emails as well from Celtic, because we do work with some other providers who do this style of course, and there are lots of places that you can get some knowledge to start you on your ultrasound or scanning journey. So yeah, get in touch with either myself, Rich, Kirsten, or indeed we'll have Mike's details as well. So if you've got any questions in the lead up, then just get in touch.
Great.
Happy, Mike?
Thank you, Tom. Cheers.
Thank you very much again, and thank you all for coming on. Leave you to your evenings, and yeah, any questions, just shout.
Brilliant. Thanks, everyone. Thank you.
Cheers, guys.